This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to give an overview of our free program for those attending for the first time. So we'll be talking about who we are, what is our program, some upcoming events, introduce our speaker, Dr. Frank Gargano, and then we'll go through a Q&A. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter Deanna leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their local communities. We've started over 65 groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities, but many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Wednesday, typically at 7:30 p.m. Eastern Standard Time. All programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Today's presentation is sponsored by Body Support Store, where you will find over 250 products selected by EDSers for EDSers. The store is the only funding for this program, and it usually covers our monthly web fees. So please visit our store and check out the helpful products that we sell. Just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you are having medical problems now, please call 911 and get the services that you require. Always consult your doctor before making any changes to your treatment.
Wanted to let you know about some upcoming events. The next webinar will be Wednesday, December 3rd at 7:30 p.m. Our presenter is Dr. Das, who is an otolaryngologist, which is an ENT or ear, nose, and throat specialist. He is also the Chief Executive Officer at the U.S. Institute for Advanced Sinus Care and Research, and he's going to talk about sinus care and Ehlers-Danlos. Wanted to remind you that there is an important EDS survey on our site found in the articles section, and be sure to fill that out. This is regarding gastrointestinal issues and Ehlers-Danlos. And just a note that in 2015, our webinars will be moving to Tuesdays, so check those out on the first and third Tuesdays of each month starting in 2015. A reminder that after tonight's presentation, there will be an opportunity for Q&A. Add your questions at any time during the presentation by clicking the Q&A icon located at the top of your screen. After typing your question, click the orange button to submit. Our speaker tonight is Frank Gargano. He has a doctorate in physical therapy, and he will discuss dry needling for EDS pain management and can muscle performance be improved. Frank has over 24 years of orthopedic physical therapy experience in treating musculoskeletal pain and dysfunction, and is the president and lead instructor for the Integrative Dry Needling Institute, which provides dry needling seminars to allied health professionals. He is board certified in orthopedics through the American Physical Therapy Association, and since 1996, he's been instructing orthopedic manual therapy seminars across the U.S. and internationally. Frank Gargano is a published author. He has authored 4 book chapters just this past year on the following concepts, including how to integrate dry needling and manual therapy in the treatment of headaches, and how dry needling can be used to enhance athletic performance. Also utilizing mobilization with movement for the upper cervical spine for the treatment of pain, dizziness, and headaches, and the neurological concept of pain release phenomenon. Frank is active in the clinical research on the effects of dry needling, and his current project involves comparing joint mobilization and dry needling in the treatment of lumbosacral pain. So with that, I am especially pleased to welcome Frank Gargano. He is my physical therapist and is truly an indispensable part of my pain management team, and also the same for many of my Cleveland EDS support group members. So I thank you very much for speaking to us tonight, Frank, and I welcome you.
Thank you, Deanna. Thank you, John. I'm hoping volume sounds okay for you guys.
It sounds great.
Great. Well, I appreciate the invitation to have an opportunity to take a look at dry needling. Is what I found to be pretty effective in treating EDS for me, and especially since in the past my normal manual therapy skills were somewhat ineffective in treating the EDS population. So I'm going to speak probably for about a half hour or so. I'll try to answer some of the main questions I think will come up. I'm going to give you a little bit of research, limited in that sense, on the effects of dry needling. And then we'll just go into some specifics on exactly the process of it. But I think the first question that people have is exactly what is dry needling? And what it is truly an invasive procedure. It utilizes a solid monofilament needle, and it's inserted into symptomatic soft tissue. So essentially, we're actually penetrating the skin with a needle, and I'll describe the different types of needles in a little bit, but it certainly is an invasive procedure. Why we do it is we want to reduce tissue tension. A lot of you in the audience certainly have those areas in your body that are tender and sore and somewhat of a knot in those, and I'll describe a trigger point in a little bit. But the insertion of that needle will actually reduce tissue tension, physically, mechanically breaking down some of that tissue tension. One of the major things that dry needling does for you is it improves your circulation. I say microcirculation, we'll talk a little bit about that. But that is one of the major things in the effect of dry needling, because most musculoskeletal pain has a degree of a loss of circulation. So we'll talk more about that. And then it normalizes physiological processes. So it's not something that when you needle someone, it makes them heal faster or makes them heal slower. It's essentially allowing the body to maximize its own healing potential. And I think that's an important part. It doesn't make anything better or anything worse. It just helps the body heal at its own pace. So there's a number of ways we can do that. This is just a simple video looking at how we set the patient up and essentially a real simple treatment of the needling. So in this case, we're utilizing and grabbing a hold of the muscle itself, taking the needle and applying it into the skin, and doing a little bit of manipulation of the needle. It doesn't have to be very aggressive in any way. So the application of that needle through a plastic applicator, simple tap, and then again the needle insertion with a light little bit of manipulation. Now that is very much a local type of an effect where I find within that upper trap we find a nodule, as we talked about, and we apply a treatment directly to that local nodule. So that effect is pretty local. And one of the things that you'll see in a local effect is going to be a treatment of what we call a trigger point. Now, on this picture to the right, where it has the arrow outlining the trigger point, that's actually an ultrasound of a calf muscle of one of my colleagues. Now, where it's outlined here, you can see a little bit of a circular or oval nodule. That is what we would define as, at least in this picture, as a trigger point. And that trigger point itself is the area that many times in dry needling people are attempting to hit. The question is, do we actually need to hit that particular spot? Or, in fact, is that general area good enough? Now, when you have these trigger points, and some call them myofascial trigger points, we call them neuro trigger points, there's a number of different names for them. But over to the left, which shows the upper trapezius, middle trapezius, and lower trapezius, we have referral patterns. Now, many trigger points, when they're particularly what we call active, they actually have referral patterns. So in the areas, in some people that have upper trapezius trigger points, you can actually see the pattern that radiates around and sits behind their eye. Others have it in the back of the neck, some in the mid-back, some into the shoulder. So these trigger points can, in fact, refer pain into different areas of the body, in this case, head and neck. So a definition of a trigger point by Janet Travell along the bottom here, which, in my opinion, is the person that really came about and started the idea of trigger point dry needling. She describes it as a hyper-irritable spot in your skeletal muscle. Okay? It's associated with that nodule we discussed and that I'm showing here, and a taut band. So a lot of you, as you wet through that upper trap on yourselves, you feel the nodule, you can roll it over like a band, and it's actually painful. Well, the spot itself, when you touch it, it's certainly tender, and it gives you that referred pain that I show up in the upper corner. It gives you motor dysfunction. Motor dysfunction meaning a muscle that has a trigger point doesn't have the same strength capability as one that doesn't. And we'll show some other limitations that trigger points do in muscles as well, but certainly motor dysfunction is one of them. And then she also describes at the bottom autonomic phenomenon, and that really deals mostly with the circulation aspects of things. And you can get a loss of circulation in and around these trigger points. And if you remember, I said a big portion of musculoskeletal pain is a loss of circulation. So these trigger points do create that. So we do want to be able to get in and around these trigger points and release them for those reasons. The picture you see off to your left is basically an infrared study. And what that infrared study is showing is somebody with shin splints or shin pain, anterior shin pain. That is just kind of demonstrating, in my opinion, more of a nerve path. So the contrast between looking at a trigger point as a purely muscular entity and one that has more of a peripheral nerve component to it is what I was showing in those distributions. So I think there's some controversy still on exactly what a trigger point is and if, in fact, it is the trigger point specifically that's generating your pain. So as we go through this, we'll talk about that more. This is an example of a local twitch response. So when we see here, I'm finding that nodule, utilizing a needle. I want you to watch right in there. As I put the needle in, you'll see the twitch. Now, that twitch is an involuntary reaction. It's like when the doctor comes and hits your knee and your knee twitches. It's that type of spinal cord reflex. But getting in and around the area of the trigger point, at times, not on all of it, but at times you will get this involuntary twitch that occurs. And that can be a little bit uncomfortable for sure. We'll talk about pain later. But it's something that when it occurs, it can be a very good thing. It's not a negative thing in any way, but it doesn't necessarily always have to occur. And when we talk about different types of needling, some people like the twitching response. Others are very, very sensitive to it and don't want it. So it becomes this, different aspect of how you needle people to help improve their tolerance to the actual treatment itself. Now, going along a little further about what dry needling is, as we still go along, we said now the effects can be local, as we saw. Now we have to look at the nervous system a little bit more. We're going to look at this in a segmental way. And what I mean by that is that our body is broken up into different nerve paths. And in this particular case, we have different C3, C5, C6 coming along in the left picture, all the way down. And each one of those distributions is talked to by a nerve. That nerve will talk to the area, either giving you sensation to that area or giving you motor control, meaning allowing that area to move. And some nerves do both. So when we look at segmental, we want to be able to treat not only, let's use an example of elbow pain. We don't want to just treat your elbow locally. We want to treat all the nerves that talk to the elbow. So we actually do needling all the way up into the arm, all the way up to the shoulder, and even all the way up into the neck itself. That's an important aspect of this, and that's called segmental needling. Last thing that we'll talk about in regards to effect is a systemic effect. That basically means that needling isn't just about local or segmental. We have research out there showing that when you needle certain areas of the body, let's use example the upper trapezius muscle, which we just needled in the video, that muscle itself can have an effect on the legs going down lower, even into the calf muscles. So when there's an active trigger point within, say, an upper trapezius, we're showing that there's sensitivity in other parts of the body. It's not just local. There's also other research out there that shows when there's trigger points in the upper trap, the actual sensitization factors that are there within the blood system and around that trigger point are actually also present in other parts of the body. So this particular picture is just one of the things that I use and that I teach is looking at the different nerve points throughout the body and showing that we are able to look at these different points and treat the body in a segmental, in a systemic way. So I very rarely treat in a very local stance. I treat basically down peripheral nerve roots, really in the entire body, depending on the specific pathology. So again, we treat local, segmental, and then systemically. That's an important aspect of the type of needling that we do. Now, how does it work in that way? I mean, what is the mechanisms that go along with this? And in this particular picture, we show, a caricature really of a needle going into soft tissue. Well, when you put a needle into soft tissue, you essentially are creating something. And that's we call it a physiological lesion, okay? In truest terms, you're putting a hole in somebody, right? A very small little hole, but it's a physiological lesion. And when you remove that needle, you still see some response to that. So we leave an opening, we leave that lesion, and the body will come in and the body will start to heal that lesion. And I think that's really what we're talking about here is there's a huge physiological response when you put a needle into somebody. And this is probably a little better picture of it. And what this is really representing is the different layers as we go down through the skin. So at the top we have the skin layer. Down a little bit further we have the epidermal layer that has vascular structures and things into it. And then the next layer below that is going to be the muscular layer. So depending on how deep you put the needle will depend on what structures that you actually affect. Different types of needling, for example, superficial needling. That's when you break the skin with the needle, but you actually don't touch the underlying muscular tissue. There's also what we call deep needling, and that's essentially where you break through the skin, through the dermis layer, and you actually needle into the muscle of various depths. So we have needles that go ½ inch. I've got a needle that will go 5 inches. It just depends on what area of the body you're needling and how deep you need to be. And that is a huge factor in needling is that we can get the deeper structures. Other types of treatments and things can't get as deep as the needling can. And that's, again, another one of those benefits, along with the physiological lesion, as well as the depth of the lesion, is really where dry needling has, I think, its strength points, not to mention the physiological things that we discussed. But I think that's really what we have to look at. And it's not just a description, if you will, of that. It's very, very difficult right now, and research is coming around more and more, and I could, which my courses are, I got 6 days of courses, I could talk to you about all the things that are coming around, but understand that there isn't a single effect right now that completely explains the benefit of dry needling. Okay, I'm sure some people are going to have questions about acupuncture and things. Acupuncture's been around for thousands of years, and there still isn't a clear-cut reason why it works, because acupuncture works. There's no doubt about that. But we don't have a specific reason for it. And scientific research now, going in along the dry needling, is coming around with more and more theories, coming out with fMRI studies, fMRA studies, chemical studies. So we're seeing that the body of literature is really starting to grow on the reasoning behind why dry needling or acupuncture or any type of needling actually has a beneficial effect to the body. But what we're going to focus on, as I talked about early on, is the circulation, the microcirculation factors that go into the needling effect. Because again, I'll say it one more time. Majority or much of musculoskeletal pain has a limitation of circulation, a reduced circulation, as one cause of why that person's having pain. So physiological benefits, let's go into that. Most purposeful function of circulation occurs in the microcirculation, meaning the capillaries, and I'll show you some pictures of those here in a second, but in the capillaries, the arterioles, the venules, it's that smaller areas that are supplying the specific tissues, the cells, where a lot of that functional aspect occurs. And the main function of that is to transport, both transport in and transport out things like toxins and CO2 and waste factors that are creating some of that inflammation and that irritation that's creating the muscle guarding and the loss of circulation. So it's this pattern of inflammation, loss of circulation, that can give you that pain that you're experiencing. So what we want to be able to do is we want to reduce inflammation of the soft tissue, but that includes the nerve structures. So when you have a tender spot in your arm or your back or your neck, okay, you're feeling muscle. There's no doubt about that. But you're also feeling all the other soft tissue structures that are underneath that, and they have inflammation in them. Most of them do, and that's, again, what some of those studies showed was trigger points have an increased inflammation around the area of those trigger points, okay? So trying to get rid of that inflammation by the needling is a physiological process, and it's a process that can take some time. And we contrast that to an MD injecting you with cortisone or an anti-inflammatory of some sort, right? And you can get an immediate response many times with that type of wet needling. Again, contrast it to dry needling, we're not injecting anything. Wet needling is they're actually injecting, and I'll show you the needle difference for that. So dry needling regulates and tries to improve inflammation into an area without using a pharmaceutical effect. And that's an important part. A lot of my patients do not want medications, or they've tried them and failed. They don't want injections because they either don't work or they don't last to any great degree. So what dry needling tries to do is come in and actually provide a healing effect for the tissue itself. So we have physiological lesion. What is it determined by? Well, the first thing is the size of the needle. So I'll give you a contrast here. A match head, a hollow bore needle, and then essentially a solid monofilament dry needle. So what we see here in the middle section is that that's where the fluid is able to be pumped through. And that gauge is considerably, gauge meaning how thick the needle is considerably bigger than what we utilize in dry needling. Now, we want lesion to occur so we can do more than one needle along those lines. But that's one factor on how the physiological lesion is determined and how the healing process goes on. But you can see even really most needles are obviously fairly small. They only feel big when they stick it stuck in you, right? Depth of the needle. I alluded to this a little bit, is if we needle just in the skin itself, okay, that's superficial needling. Usually not painful, usually has some physiological effects, but deep needling is what this picture shows, is that you're getting actually into the soft tissue and into the muscle tissue itself. Studies show that deep needling is more effective than superficial needling. However, superficial needling is better than nothing, meaning better than sham or better than not doing it. So it's just various levels of that. And it depends on the patient's tolerance to how they tolerate needling, and usually we'll work them up into a higher level of needling. So we want to make sure that when you decide to do needling that, you know, the person understands that at various degrees of buildup. And then lastly, its physiological lesion is determined by the tissue involved. And what this picture actually is a close-up view of muscle fibers that include, and again, hopefully you can see the CA, the VE, and the AR, that's the capillaries, the venules, and the arterioles. This is where the microcirculation occurs, okay? Within the microcirculation is where all those oxygen and those waste products and things are put in, taken out, and this is where a lot of that happens. So when you put a needle into this structure, this gets damaged. Simple as that. It gets lesioned. The body comes in and takes the tissue that has been contracted, it has inflammatories, It's been nasty, it's tight, it has all those bad things that you're feeling when you feel your legs and your arms and your neck. And it goes in and it disrupts that. And it forces the body to start to regenerate the area. So after dry needling, this picture you see will be damaged. Give it about 3 to 5 days to 7 days, depending on the person, right? And that will be restored to as normal as possible as the body can heal. And that's really, I think, physiologically where you get the benefit of that is that physiological lesion. On a bigger scale now, what we have, and I'm going to do one thing for you guys. I'm going to take that off for just a second. I'm going to put that back up again. There we go. My pointer was lost here. So let's go through this. We've got, again, soft tissue. We put a needle into it. The first thing that happens is a alarm is set off that your nervous system picks up. You know, anytime anything happens to your external body, your nervous system is made aware of it. The next thing that occurs is the body immediately starts an immune system response. It goes to heal that area. Well, we talked about the immune response. The nervous system response we talked about a little bit. But then it also mobilizes many other factors within your body, including the endocrine system, the cardiovascular system. It actually gets the body kicked into gear to go and heal that foreign invader that's been into your body. So it starts the process of a physiological self-regulation. It doesn't make you heal any faster. It doesn't make you heal any slower. It maximizes your own body's ability to heal. So if you're a 20-year-old person, your healing capabilities are probably stronger than a person who is in their 60s, 70s, or 80s, right? Not always true, but that's sort of the thought process. So we maximize your own healing ability. If you're sick, your healing ability is less. You may need more dry needling treatment before you see this physiological process continue to go along. If you're younger, the process of dry needling probably will show benefits a lot quicker. So why you came tonight? This is why you came tonight. What can this do for an Ehlers-Danlos person? Well, I want to introduce Christy. I guess my best way is from a case study standpoint is Christy's been a patient of mine now, I think it's going on about a year or so, and Christy's a nurse. And I wanted to get her perspective because, you know, from a medical professional side and a patient side, it's a nice perspective to actually have. So what I asked her to do, and she was nice enough to do this for us, I saw earlier this week, I asked her to write up a little bit about her experience with it. And I think it's fairly relative because this talk was about pain management, of course, but I want to go into something that's a little bit different. I want to go into muscle performance. And improving muscle performance is, I think, where I try to focus a little bit more with the EDS population. I'm going to explain that a bit more. But with Christy, she obviously got diagnosed 14 years ago. She tried a number of different types of manual therapy. She tried different types of medications, those types of things. And a lot of the times, the physical therapy that she received made her worse. Basically, she ended up having problems with just the tolerance of being able to do it. And the fatigue factor that went along with that was quite significant for her. So every time she ended up trying to do something, even simple tasks, she always, and I hear this a lot with my EDS patients, is they say, if I do that, I pay the price. Okay? What is that price? Well, that price is the soreness and the fatigue that goes along with this. Now, Christy also has POTS, postural orthostatic tachycardic syndrome, right? Many of you are familiar with that. We can talk about it later if you want. So part of her fatigue certainly comes along from that. But I also believe that part of her fatigue comes from the idea of these trigger points that are within her system that are reducing her circulation and making it more difficult for those muscles to perform. So when a muscle has more difficulty forming or underperforming, you have to work harder to make it happen. So one of my goals when I treat particularly Christy was to try to treat these areas and improve the muscle's ability to function. As I'll show you in a little bit here what trigger points do to muscles. But we started with her, and I started seeing her once a week. She lives quite a ways away, probably 45 minutes to an hour away from me. So we saw her once a week, and we did that for several weeks. And we've tried to continue to back off on this, which is pretty common for my patient population of migraine, dystonia, EDS, and different people with chronic conditions, is we start them out, try to hit them hard, and then start to back it off a little bit more with their treatments. But we're now at every 2 weeks, maybe 3 weeks, something like that with Christy, and slowly her activity levels started to increase. And our last visit with her, talking about yoga, talking about working in the pool, talking about light exercise. To me, that's what I want to hear about, particularly with EDS people, functioning at a better level. Now, obviously, there are certain degrees of EDS that this may not be possible with, but we don't know it till we try it in that way. And again, I love this statement where she says, I don't pay for my activities as much. The cost isn't as high. And that's a huge victory in my mind in treating EDS people. Okay, and so I appreciate Christy for doing this. I really like the path that we're on with it, and we'll talk a little bit more about treatment stuff in a second. But let's talk about how the body actually moves. I think that's pretty important. Our body moves in a push-pull type of situation, or an agonist-antagonistic way, meaning if I bend my elbow, my bicep contracts. Well, at the same time my bicep contracts to bend my elbow, my tricep on the other side has to relax. So there's this give and take as we move through the system. Now, when somebody has trigger points, those trigger points affect many things. One of the studies that I won't go through, but one of the studies showed that when you have a trigger point in a muscle, that it messes with the ability of its antagonistic muscle to contract. So that push-pull, that give-and-take mechanism becomes altered. The fine motor control gets off, and just the sheer ability of that joint to move coordinated becomes reduced. I have about 3 or 4 other studies that I could certainly discuss and question and answer if you want to, but it shows when you have trigger points in your body, the way your body moves is altered compared to people without these trigger points. Now, within EDS population, that's huge for you because you can't afford to have altered movements around your joints. You already have joints that aren't being supported properly, so your muscles have to work a lot harder to support your joints. And this is where the muscle performance concept comes in, to improve the muscle performance to support the joints that don't have the support from passive structures, like the soft tissue and the different types of capsules and ligaments that we normally would have there supporting the structure. Now, to go further along with the idea of mechanical influence of these trigger points on you, on your body, we know there's evidence that supports the relationship between motor dysfunction and these trigger points, okay? When you have trigger points, your muscles don't perform properly, and you end up having a loss of control around those joints, okay? That has been pretty well documented in the literature. Secondly is, and this is even old stuff with some new stuff around it, is that when you have a trigger point, you in fact, the trigger point in fact restricts the range of motion of the muscle, but also of the joint that muscle supports. So now a lot of you have loss of motion. Some of you have, interestingly, going the other way, have too much motion. But if you really look at some of your structures, you're actually limited in some of these areas, whereas other ones are just ridiculously mobile, right? So there's that give and take structure is way out. We ought to be able to try to focus in on those areas that are there and try to get stability and motor control, if that's possible, in those particular areas. The other thing that we see is that there's increased motor unit activity, okay? There's a hyperexcitability around these trigger points. And that's one of the mechanisms that creates muscle cramps. And these muscle cramps can be really, again, trigger points, because that's kind of what a trigger point is at the muscle level. It's a bit of a contraction or a cramp. So we already know that from the loss of circulation, which we talked about earlier. So we've got this motor dysfunction where your muscles aren't firing properly, your joints aren't moving properly. You have limited motion in certain areas of certain muscles. You have these muscle cramps and loss of circulation. You put all these things together, and we get this thing called accelerated muscle fatigability. Now, there's not a lot of research on this, but it would seem to just empirically make sense, and clinically it certainly makes sense, that when you get fatigued at the end of the day, assuming we don't have some of the other chronic fatigues in the pop, let's just say we don't, but at the end of the day, you're fatigued and you just got to lie down. I think a part of that comes from the idea that the muscles themselves are struggling. They're struggling to get the oxygen and the circulation that they need, so they start to have problems. So part of that fatigue, in my opinion, would be that accelerated muscle fatigability, which can hopefully be improved with the proper type of activities. And that's really what we need to talk about, too, is when we start to look at treatment, right? So before I talk about treatment, let's talk about what dry needling may or can accomplish. Well, I think it's going to be pretty darn good at soft tissue guarding and tightness. I mean, there's enough research that says to us that when we stick needles in these areas start to loosen. And just empirically, we see that with patients all the time. Yeah, that moves a lot better. Yeah, I've got a lot better motion. So I think we got good support there. Improving circulation, we have moderate support there. We have some really good articles demonstrating that, and I've got some newer articles out looking at why that is with nitric oxide and different types of chemicals that are released that allow relaxation and dilation. So I think we've got some good research behind that. Reducing the associated soft tissue pain. You know, we have a lot of good case studies, and we do have some pretty decent studies on pain pressure thresholds demonstrating that dry needling does reduce pain as compared to not doing it or sham types of studies. So I think that's pretty well documented in the literature as well. Improvement of joint and segment range of motion. Sure, I think if we get rid of trigger points, we improve motion of the muscle, it'll improve motion around that segment in the lumbar spine, or even in and around that extremity joint. So good stuff there. And then improvement in muscle activation patterns. I alluded to this a little bit, and there's about 4 articles out there that talk about the timing of how you move your arm, and that when you have trigger points, the timing of the muscles to support your joints is off. And if the timing is off, the joints take more beating in that sense, especially in an EDS patient who doesn't have the inherent stability. So improving muscle activation patterns, I think, is a very important aspect of EDS treatment when it comes to dry needling. What dry needling may or cannot accomplish: abolishing centrally generated muscle tone. Now, what I mean by centrally generated tone is something that isn't from the peripheral system. A good example of that is comorbidities that EDS patients can have. I just gave a lecture down in Charleston, South Carolina to the Dystonia Association, and dystonia is a centrally generated neurological muscle tone, essentially. And with those individuals, I can change the peripheral stuff, but I can never change the centrally mediated tone. I can only modulate it for a period of time. Well, it's the same thing here. The EDS patients that have POTS or that have other comorbidities, we can't change those. So it is only a modulation, if you will, or a mitigation of those symptoms. What may or cannot accomplish completely may be complete pain relief. You don't want to go into the idea that I'm going to try dry needling with the idea that it's going to cure your pain. It may, but more than likely it's going to make a difference in your pain, and it may or may not have a lasting effect. It could be days, could be weeks, maybe even months, depending on how bad that is. But don't have that I would say, somewhat unrealistic thought when you go into it. But it certainly will help with pain relief. Restore muscle strength to normal. It will allow your muscle to function at its best level, but it certainly isn't something that produces muscle strength. It's something that you need to obviously work with, and that's where a good physical therapist comes in to be able to structure a program for you, as we'll talk about shortly. It may or cannot restore full range of motion. That's, again, a structural thing with each individual, but we should be able to improve range of motion where we want the range of motion to be improved, and where we want the range of motion to be reduced, if you will, or stabilized. It'll improve your muscle performance to maybe allow you to do that. And then lastly, does dry needling replace the need for other forms of management? Well, the answer to that in the majority of cases is absolutely not. Now, I treat some patients that I essentially only do dry needling with them because they can't tolerate much of anything else. And some see other practitioners as well along those lines. But I at least try to be able to go in and do other forms of treatment. And that's an important aspect to this as well. And those other forms of treatment can be many different things. Manual therapy is huge. You know, I do a lot of manual therapy. I teach a lot of manual therapy. And I believe in that. And I still believe in that with the EDS population. Manipulation or mobilization, I think, are very, very good. One thing you have to be careful with and you have to be aware of is you can't get aggressive with the mobilization or the manipulation, right? The joints, many patients' joints don't tolerate that. Now, with Christy, back to Christy, I manipulate her. I manipulate her lumbar. I manipulate that. I manipulate her thoracic or cervical. I do it very specifically. I do it very gently. And she responds well to that. Okay? In other of my EDS patients, I would never think of manipulating them, right? You can, though, however, go into situations where you do mobilization. And the difference between manipulation and mobilization is essentially that in a manipulation standpoint, your joints are taking to an end range at a speed that you cannot stop. You can't control that movement. Mobilization is performed, again, in the joint, and it can be at various ranges within a joint range of motion, but it's performed in a way that you can guard or you can stop it. So it's a slower type of joint movement, and still very, very effective, I believe, with the EDS population. Exercise. Well, we talked about that. I said one of the major things that I try to do is get my EDS patients to start to move in a graded, progressive, tighter way, if you will, as we start to move through this. If you're going to use dry needling, you want to do some form of exercise because exercise will maximize the muscle performance and help, if possible, to stabilize joints that have otherwise no passive stabilization to them. And this is where you need to be evaluated by a physical therapist who has good understanding of exercise tolerance or exercise prescription. So I do think that's an important part of that. A lot of people ask me about massage. And, again, it depends how aggressive it is, because just like needling or manipulation or mobilization, some of the EDS population can't tolerate aggressive massage. But massage is fantastic for improving circulation, okay? It's a relaxation. It's a pain management tool. I like it a lot. But what you'll find, and if you're a person that says, you know what, when I get a massage, I feel fantastic, and I have better motion, I feel better, I always ask my patient, that's great, but for how long? And they say, probably about 2 days, 3 days, maybe a week. And I say, if you respond to massage, you're going to respond even better to dry needling. And you can combine the two things together because massage can work soft tissue and improve circulation to the point that it can get down to that level. And earlier I said one of the benefits of dry needling was we can get deeper. So in a hip, in a low back, in a thigh for that matter, when the problem is deeper, closer to the bone, closer to the spine, you can't push hard enough, nor can you tolerate that kind of push to get deep enough to get and influence those tissues. But you can take a 38 gauge or a 34 gauge monofilament needle and you can get to that structure. And you can improve circulation, reduce tension, all the things I talked about before at a deeper level. Combine that with massage, combine that with exercise, I think you got something there. Heat therapy. Well, everybody asks, well, should I put heat or cold on it? I think the vast majority of you in this audience probably agree that heat's probably better. There's probably a few that would like ice more, but I don't believe in ice a whole lot. I believe in heat because it improves circulation to that area in such a way that I believe it's comfortable, and I think that there are better ways to do it, particularly in muscular structures. So I think heat therapy is actually quite good. There's probably other types of therapies that you've tried. I mean, we could probably talk about those. I mean, this really is where I've come down on looking at EDS is these basic areas here is where I focus most of my time. So I think some of the more physiological kinds of stuff, treatment concepts we did, but I think there's one question that people are going to ask. Does it hurt? Well, I alluded to that a little bit in regards to the types of needling that are out there. So if somebody comes in and they're extremely hypersensitive, they're extremely nervous about getting needled because they found their friend had fixed that, so they want to come in and they want to do it, but they're scared to death of needles. Part of the issue is if somebody's that fearful of needles, we don't needle them. That's one. But if they're really, really hypersensitive, we start with something like a half-inch needle. So the half-inch needle is superficial needling. Remember, superficial needling is break the skin but not tap into the muscle. Usually very well tolerated. You will still get a physiological result of that. Again, not as strong as if you go deeper into the muscle, but it's a nice starting point for people. That doesn't really hurt. When you start getting into the deeper muscles, you will get a couple things. One, you'll get that local twitch response that we saw earlier, where the muscle will twitch, and that can be pinchy. You obviously getting needle stuck in you, so there can be a pinch to that. You will get an aching sensation. Now, in ancient literature, the aching sensation is a very good thing, and I still, to this day, an aching sensation is a good thing. It's a physiological process that occurs. Is it all that horribly painful? No, not really. But then there are times where you'll hit different structures. You can get a little bit of electric shock. You can get a little peripheral nerve. It doesn't really hurt anything per se, but it's certainly shocking, if you will. And you can also get areas that you get into that are just downright painful. And those are areas that we would not necessarily needle in that way. So a practitioner that understands various forms of needling can make the needling experience fine. I mean, you can make it to where it's very, very comfortable. And as you need more types of needling techniques, they can let you know when this area, I think this area is really going to hurt, type of thing, and you guys can discuss that. So it can be a positive thing. It doesn't have to be negative, like some of the things I see in the YouTube videos and some of the blogs and how excruciatingly painful it was. That's a practitioner issue, okay? Not a needling issue. That's a practitioner issue more than anything else. How will I feel after needling? If you're expecting to see the sun and like this guy is here, some of you will feel that way. Some of you feel almost immediate relief. And I don't just mean EDS, I'm talking about my patients. It's an immediate relief of pain. And it's almost like this guy here. You can almost hear the music of this guy, right? So that happens. There's no doubt that happens. Other people don't feel an immediate response. In fact, they feel sore. They feel sore that day, probably a day, day and a half afterwards. But then the body catches up. This is particularly after the first needling. The body catches up, and they start to feel better and better. And it may, in fact, take a few sessions because, remember, we're not using medication. There's no medication in this. There's not a thought that it's going to have an immediate effect per se, but there is a buildup of the body healing itself. So it can take some time, several visits for sure along those lines. Other people will say, I just had somebody come back. She's on the call, I think. She went home and she slept for 12 hours. So I see that a lot. I hear that a lot. That, after I left you, man, I went home and I haven't slept that good in years. Other people will say, I felt fatigued the rest of the day. Other people will say, I felt energized. What did you put in those needles? Nothing. But I just felt energized the whole day. I felt really, really good. And there's a number of other types of sensations and things that people can actually feel. But none of them are all that drastic. In fact, the research on the safety of dry needling is very, very good. They call it adverse reactions or adverse events. They're very, very minimal. In fact, the biggest adverse event that was listed was minor bleeding. Okay, you take the needle out, you get a little bit of a bleeder, compression on it, you're good to go. Probably get a little bit of a bruise. Bruising is another, adverse event, if you call it that you can have from dry needling. But there really is, it's a very, very safe procedure. In the hands of the right practitioner, it can be a fairly comfortable procedure as well. It doesn't have to be horrible. And I think it's something that from an EDS standpoint, I've seen enough EDS patients, enough dystonia patients, enough migraine patients to know that there is value in its use and not in its single use. Using it and combining with other treatment modalities that can be offered by physical therapists, chiropractors, osteopaths, MDs, things like that go along and that can offer a wide range of it. So I don't think you want to use it as a standalone treatment, but in combination, I think it's actually quite fantastic. So at this point, I think I kind of yacked enough. I'm going to go ahead and open up the floor for your questions. Hello? Let's go to here real quick.
I'm going to transition back to another slide. Go ahead, Deanna.
Oh, okay. Thank you, Frank, for the very informative presentation. We're really excited to ask you a lot of questions. I'm sure there's quite a few that came up as you were talking. One of the big questions that people are having is how do they find a practitioner near them? So that's one to just keep in mind, whether you have any input and help for them to find somebody locally.
Yeah, I think what you that's a tough question too, because quite honestly, dry needling is still very new, particularly in the physical therapy community. It's almost unheard of in the chiropractic community. I'm getting more and more chiropractors in my courses, but a lot of the chiropractors practice acupuncture along with that. So that's another thing, and I probably should just throw that out there right now. Because that'll be a question, I'm sure. What's the difference between dry needling and acupuncture? So when we look at that, a lot of it has to do with training. So dry needling itself is something that's performed by physical therapists primarily, but there's definitely chiropractors that go along with it. As a physical therapist, I don't have any training in acupuncture. And acupuncture really has been around for thousands of years and is really part of an ancient Chinese medicine, which is based on Chinese philosophy and clinical experience to treat human diseases. We're not treating human disease with dry needling. We're treating musculoskeletal dysfunction, and we're basing it on the muscles, we're basing it on the peripheral nervous system, and even the chemistry of what goes on. So, when you look at a background of somebody who does dry needling, we have usually 4 years of undergraduate training. We have 2 to 3 years of professional training, and then we have actual dry needling training in specialty courses. That differs from acupuncturist training, who focuses in a little bit more on the classics of acupuncture, where they look at theories of yin and yang and meridians and pulse and tongue diagnosis and disease classifications based on Chinese medicine. Those are really two of the biggest differences, is one in the training and two in how we're approaching the different dysfunctions that people present with us. Both work. Both have a very similar mechanism because we're both needling the same human body. So when you needle a body, whether you're an acupuncturist or you're a dry needler, the physiology of the body really is the same. It's the theory on why you're needling and where you're needling to a certain degree that really differs. But I encourage people that, dry needling is certainly something that's good. If you've tried acupuncture and you've had success, stay with it. And if you haven't, dry needling and all the other things that the physical therapists and the chiropractors and the osteopaths bring to the table, they can add to, in addition to the dry needling, maybe something that's helpful for you.
Frank, you can click the Q&A.
Yep, I got it right here.
You got it? Okay, fabulous.
Yep, I got it. First question. I recently heard about physical therapy approach called integrative manual therapy, or IMT. I believe it was developed by a woman in Connecticut named Sharon Giammatteo, and I'm curious to find out if this type of therapy has any validity in the treatment of EDS. I know Sharon. She taught courses for the same continuing education company that I did nationally, but I do not know if she is saying that IMT, integrative manual therapy, is specific to the EDS population or not. I would imagine it would have benefit, but I'm not familiar with that particular technique to answer that. Question 2, post-injury as an auto whiplash injury, is dry needling effective? Absolutely, it's effective. Auto accidents as a whole, in my opinion, obviously are soft tissue injuries. Now, if you have EDS and you get in a car accident, that's a horrible thing because, A, you don't have the soft tissue structures to support you. So when you actually get a whiplash effect, you probably create a heck of a lot more damage than the 6'2", 240-pound football player with a huge neck, right? That he comes out, who walks away from car accidents because he's got so much support structure. But in regards to dry needling, whiplash is an inflammatory event that occurs and stays that way. So based on what I discussed, dry needling for car accidents is absolutely fantastic, and I would highly encourage you to seek care for something like that. I see lots of those types of people. Next question. Can dry needling help to stabilize hypermobile joints? No. I have some people ask me, and it's a great question, they say, well, I've got these nodules around these tender points or these trigger points around the joint. These things are tight. Are they helping hold my joints together? That's the first question I'm always asked. And the answer to that question is no. These are small, tiny nodules they have no ability to hold your joints together. Having said that, when you release them, they will not make your joints more loose in that sense. By releasing them, you are actually improving the muscle's ability to perform, to function, which may allow you to exercise, which will eventually, hopefully for different people, provide stability to the joint itself. I liken EDS patients to swimmers. Now, swimmers' shoulders, when they're in season, these guys they do crazy amounts of work, right? So when they're in season, their rotator cuff, their muscles are at the top of the shape, and they're doing well. When they stop swimming, the muscle tone reduces, and then it's when I usually see them with shoulder pain, because the muscles aren't supporting those hyperflexible joints that they have when they do all those different swimming strokes. So in an EDS situation, same thing, reduce the trigger points, improve muscle function. I answered the acupuncture one, I think. Have you found any efficacy with dry needling and burned skin, scar tissue, scar bands? I'm not aware of research that shows that dry needling affects scar tissue. However, empirically, scar tissue we know brings in nerves, and scar tissue can become painful. So I have personally needled into many, many scars, post-surgical scars, or long-standing scars. I put needles in, and I also add electrical stimulation. What the electrical stimulation does is it causes the needle to vibrate, okay, move and actually vibrate. It's that type of vibration that helps with, I don't want to say breaking up the scar tissue, but helps with the remodeling of the scar tissue to allow you then to range of motion the scar tissue, mobilize it, get it moving, and helps with the pain as well. So the short answer to that is yes, dry needling in combination with electrical stimulation I think is very effective for scar tissue treatment. How does dry needling compare to prolotherapy? Prolotherapy is an injection of a sclerosing agent. It is, again, a hollow needle that injects sclerosing agents into soft tissue, which is designed to create, essentially, scar tissue. So people that have really hypermobile joints, and again, I'm not an expert on prolotherapy, but they inject into the capsular areas, ligamentous areas, create scar tissues in an attempt to bind down the structures. Dry needling does not provide any type of injectable. How can dry needling be used to treat autonomic issues associated with EDS, such as POTS? A lot of my patients have POTS that go along with that. And with POTS, I wrote a paper on POTS. It's on my website. It's just about symptoms and lay person type of article at rehabilitex.com under interesting articles. So I'm pretty familiar with POTS. Do I think dry needling has a big effect on POTS? Short answer is no. If, in fact, we can get somebody to exercise at a little higher level, that's one of the treatments for POTS, and I think it's indirectly may help a POTS patient, but in regards to directly doing it, no, I don't think that it really has that big of an effect. You mentioned that it doesn't heal you any quicker, but if it maximizes your healing that otherwise might not be maximized, then it really does help your healing. Yes, no. I think you're right. I think it does help your healing, but if we just use an example, you heal at 35 miles per hour, okay, using a speedometer. The max you can go is 35 miles per hour in your healing, and I'm not, by sticking dry needling into you, going to make you heal at 55 miles per hour. Okay? We can certainly make you heal at 15 miles per hour. So by maximizing it, we get you back to where your body can heal at its maximal abilities. And that's really what we're trying to do is optimize the physiological healing, or the homeostasis, if you will, of the body's abilities. What activities or exercise do you use following dry needling session, like treatment with Christy or other patients with EDS or general trigger point problems? I think it's really independent. I have, again, using Christy as an example, she started in the pool. She starts working on elliptical. She's doing some yoga stuff right now. I've tried with other people to try to get them to exercise. She's doing active motion. That flares them up. We're doing some light resistance types of stuff. That flares them up. The pool is always probably a good place for most of the people to go, but then there's a fatigue factor. The pool is pretty fatiguing So some of the limitations of exercise are just the pure fatigue of it in a pool. But pool exercise and light active motion generating up into some very light resistive training and cardiovascular training is really what I recommend to the people. And a lot of my patients, I basically say, just move, just move is really what I'm going to do, want them to do a little bit more than they've been doing. In your experience, do EDS patients tend to heal slower than an average person or not reach as high of an optimal level? For example, following major hip surgery, after a period of several years following surgery, is it still possible for an EDS patient to improve? I think, if you're, the EDS patients themselves, do I think as a whole they heal slower? I don't know that they heal slower. I think they progress slower when we're talking about goals within musculoskeletal goals. And can somebody, get better even after years after a hip surgery? Absolutely. And I see patients all the time. I don't even worry about dry needling with them. I can help somebody with manual therapy after years of having dysfunction, because it's not always just about the muscles. It's about the joints and the muscles and the nerve interaction and how the body moves. So combining manual therapy and dry needling can help somebody who's had years and years of dysfunction improve. So I don't think it's an EDS question as much as it is, in general, people can get better even after years of having dysfunction. The EDS population where that comes in is a little bit more about how they perform and how their soft tissue performs. So that's where the slowing process, I think, in that population comes from. Does insurance typically cover dry needling? There's probably a half-hour answer to that, and I'll cut it down. But the idea is there is not a CPT code for dry needling. A CPT code is what medical professionals use to bill insurance companies. So there eventually will be a CPT code, and dry needling will be covered by insurance carriers. Right now, most practitioners are utilizing dry needling under other codes. Some use manual therapy, some use neuromuscular, and they're using it as an adjunct to what they're doing with their manual therapy. Now, some just charge flat out, say the insurance doesn't cover it, and it's a private pay situation where you show up and you give them X number of dollars. And again, that's variable. It could be $10, could be $80, don't know. And so in a private pay situation is another way of accessing that. But every region of the country has different insurance rules and different insurance providers. So it's really not a question that is able to be asked. That's something you would need to call your particular provider and ask that question and what their policy is on that. What kind of specialist does dry needling, and how do you find one? So I think, again, physical therapists right now are probably the main ones doing it. Chiropractors are getting into it more. Finding one is, again, a bit of a challenge right now. On my website, I'm looking at doing a practitioner database search. But you can call local physical therapists. You can call local chiropractors and inquire. Most will have it on their website. So you inquire about, people around your area in the PT realm, and you can inquire about their ability to perform dry needling. Now, some states, California, New York, Florida, Pennsylvania, Tennessee, maybe South Dakota. There's about 7 or 8 states that do not permit physical therapists to do dry needling. So if you're in any of those states I named, you can't get dry needling from a physical therapist anyway. A lot of other states don't permit chiropractors from doing it. So again, those state guidelines are questionable. So again, on my website at integrativedryneedling.com, I have a place where it says scope of practice. You can actually go down and it'll tell you whatever state you're in, if in fact physical therapists at least are able to do dry needling. I apologize. I apologize. I know I went through this, but can you please go over the muscle fatigue information? Muscle fatigue weakness is probably my greatest limitation of all. It can be caused by my EDS or POTS or both. How can I improve this? Well, the POTS is a different story. Again, go to rehabilitex.com. Go to interesting, I think we'll call it interesting articles to read a little bit more about POTS. But again, the muscle fatigue aspect comes from a number of reasons. I'm in no way saying that trigger points are the only reason for muscle fatigue, but based on the research and both empirical knowledge, that getting rid of trigger points in inflamed areas improves circulation, which improves muscle performance. And that, along with the other adjuncts of exercise, may help with fatigue. But it'll be a slow process, particularly if you have POTS, because your exercise tolerance is poor. It'll be a slow process, but one that you have to go with. You have to push along with that, because there really isn't a medication or a pill that's out there that's going to make any of these things any better, per se. It's still going to require the work that you need. Great job. Thanks, Donna. My daughter had dry needling done before she was diagnosed with EDS. She fell asleep during the process, and her PT was very concerned. He told her most patients would have been very uncomfortable. Is this high pain tolerance typical for EDS? Well, it sounds like you passed out, actually, because a lot of times you can get, particularly if you have POTS, particularly if you have low blood pressure as a whole, you get a vasovagal reaction. And a vasovagal reaction is essentially you pass out. And that is a reaction that can occur in some people with needling, particularly in the early going. And you can get away from that by lying them down. And it sounds like this particular PT was good at what she did. She lied, or he did, lied down and needled, and she appeared to, fall asleep. But possibly she passed out along those lines. I'm assuming she was fine when she woke up, and that's usually what happens is if there is a vasal reaction, the person then, wakes up and they're fine from that. I'm a PT whose clinic gets a lot of EDS patients, but no one really knows how to treat them. What is your usual general exercise program? What do you recommend to start with for EDS patients? Well, Laura, that's a great question, and again, it goes back to, every one of my EDS patients, I probably start with dry needling, because again, most of them are coming to me for that, because in years past, when I didn't needle, I didn't have a whole lot to offer fibromyalgia. I didn't have a whole lot to offer EDS. Now that I have needling, I have both a neurological and a physiological effect, and that's what I would start with them. I would try to get rid of as many of the local, but also the systemic trigger points. And I showed you that needling chart that I had that had all the nerves listed. That's part of our protocol. Those are the key nerve areas that we would needle to try to calm the system down, and then from there, slowly build that exercise program up. I really can't give you an exercise protocol or a particular exercise, like I would say, go and do TRX or whatever, some of those. I mean, I don't have that particular protocol. I actually the biggest goal and the biggest success that you can get in the early going is they come to you and said, I'm sore. And you're like, why are you sore? Well, I did that walking you told me. I did this, I did that. That's why I'm sore. So when an EDS patient comes to me and talks about muscle soreness from movement, that's a huge success, and then you start on the right path. What's your experience with cupping for EDS? Have you seen it to be quite beneficial? Cupping is, for those, it's also called vacuum therapy. Cupping essentially is you put a cup onto a body, use a negative pressure, and it literally sucks up the skin and the soft tissue underneath that cup. And when you pull the cup off, you've got a big circle hickey, so to speak, sitting on the skin. And what that does is it improves microcirculation. In fact, my mentor is, and I teach cupping in my courses, but my mentor is going to be Dr. Ma. He said he's writing a book on actually cupping and microcirculation. So when you look at it from a standpoint of EDS, it's a fantastic way of increasing circulation. I wouldn't say superficially, but not as deep as needling. But it also is an interesting way of providing a tissue stretch. Most stretches occur with compression. So you kind of push on somebody and you stretch them, or you just stretch their leg. That has a compressive force to it. When you cup, you are literally distracting the tissue, pulling it into that cup and stretching it in that way. So that stretch is much different than any other stretch the tissue has felt before. I like it. Sometimes I use it instead of needling. But when you talk about an EDS person, that's a different ballgame, I think. I'm not sure that would be my first go-to, or even my third or fourth go-to in EDS, because I'm not sure I want to actually put that kind of tissue stretch through an EDS's tissue, specifically if they have, obviously, skin EDS, where the skin itself is very pliable, but just any musculoskeletal stuff. I'm not sure I want to put that kind of force through it, quite honestly. So I don't think I would use that on an EDS person as a first line. Is pressure required for needle insertion? I'm sensitive to pressure. interestingly, fibromyalgia is another great example of this, but when I put my thumb on a fibromyalgia patient, I poke on them. They hate that. They absolutely positively hate that when I poke them with my finger. When I put a needle on them, and really the process, you saw the video, if it's a plastic tube, you set it on the skin, and you produce a quick tap. That tap sets the needle, and the pressure that it takes to put the needle in is far less uncomfortable to most, I should say, than the actual pressure of me putting my thumb on them and trying to find a spot to poke on. That's why when you get needled by people that have been trained by me, you won't get a lot of heavy palpation because we don't need to find a particular point. We're utilizing needle, peripheral nerve needling, or using basic surface anatomy to be able to needle into those points. So I think you would do okay with dry needling because the amount of pressure that is required is far less than what would be required of massage or deep palpation. Our needle is inserted in the muscles. Yeah, we went over that, and it could be skin or a muscle. I have several credentialed dry needling therapists where I work. What is your typical dry needling protocol for EDS patients if you would recommend a starting point? I think we talked about that. One is ready. Is start light, superficial needling, build it up into more of the deep needling. Many won't tolerate a lot of twitching, a lot of pistoning. Pistoning is where, you saw it a little bit in the video, I did a little bit of that to give you an idea, but pistoning is where you insert a needle and you start going up and down looking to create that local twitch response that I showed in the other video. So that can be fairly uncomfortable and probably not something on an EDS population I would start on day one. But certainly you can eventually evolve into those areas that really need that excessive or that extra dosage of needling. I think you can certainly go into that, start light and build up. Do you typically take a systemic approach to EDS needling? Specifically, if no myofascial trigger points are evident, how do you generally start? That's an exactly perfect question because I don't typically go for a specific trigger point area. I start with systemic needling or peripheral nerve needling. Because the reality is, most of you on this call, if you came to my clinic and I started poking on you, there wouldn't be very many places that weren't necessarily tender. And if you got comorbidity of fibromyalgia and chronic fatigue and everything else, you're going to be more of a question of where you're not sore than where you are sore. And in my opinion, that is a central nervous system inflammation or a central sensitization, and I can access that to the best of the ability by needling into those points I showed you. So I start with peripheral nerve needling in particular areas to try to desensitize the body. That then allows me to go into more focused or specific areas that they may in fact have trigger point problems, like upper traps are pretty common areas, calves sometimes, those areas. So that's a great question, and that's how I would approach that. Between needling sessions, if trigger point becomes active, what is recommended action? Try to exhaust the muscle through general activity or rest? Well, Christy, that's a great question. And what happens is, let's talk about an active trigger point versus a latent. So what I described to you is if you walk into my clinic, a lot of you on the call, you walk into my clinic and I can touch you pretty much anywhere in the body and you're going to be tender. Some of those points you're very much aware of. That's an active trigger point. Other points I touch on you, you had no idea they were tender. That's a latent trigger point. Latent trigger points can become active with a number of different things, like activity, like sickness, like illness, sometimes medication, sometimes food you eat. So anytime the body gets stressed in a certain way, these latent trigger points that you weren't aware of now become active again. So we actually play a game of active to make it latent. Try to do things to help that trigger point not become active again. So most of you are harboring many, many, many latent trigger points, and you're only harboring the active ones that you know about. And that's usually what you're coming to me or other practitioners saying, it hurts here, it hurts here. And when we feel you, we say, and it also hurts here, here, and here. So how do you stop it from becoming latent to active? You probably don't, quite honestly, because once you have a trigger point, you are the proud owner of that trigger point for the rest of your life. You're just trying to manage what's going on. And the more the muscle has performance, it has tolerance, you have tolerance, the less likely it will become active. When it becomes active, I think heat is probably a good thing for you. I think light activity is probably a good thing for you. And some of you obviously have some rescue medications, if you will, that you utilize, which I don't particularly like, but I understand you have to use that. But it is about preventing the next active trigger point, not always treating the current one. And that's where the difference is between only focusing in on pain management and focusing in on the things that are better for pain management, which is trying to maximize performance and get health of tissue, which will ultimately give you pain management. So can we look at specifics of needling where EDS with the hypermobility issues, what is the advantage of dry needling? So can we look at specifics of needling where EDS with hypermobility issues? Yeah, I think, you know, as most of you have probably an excessive amount of mobility in those areas, dry needling will not make you more stable. Again, I can't say it more specifically than muscle function, muscle performance is the only thing I can see that will give you that stability outside of obviously external supports and such. But that's really the issue. But dry needling will not make joints more stable in and of itself. Unfortunately, in Florida, dry needling is not available. Any comments? Yes, I would call the state licensure board of the American or the Florida Physical Therapy Association. Let them know that there are 40 some other states that allow dry needling to be performed by physical therapists, and you'd like to understand why you're being prevented from accessing this treatment when 40 other states and millions of other Americans can access it. So it becomes a grassroots effort, both from a physical therapy standpoint, and I get lots of physical therapists calling me in Pennsylvania and Florida asking me what to do. What to do is writing letters and calling people and making a voice for yourself, because that's the only way that's ever going to be able to be done in Florida or any other one. Do you dry needle children? I had a question in one of my courses. It said, what's the youngest kid you ever needled? And I thought about it a minute, and I said, 8 years old. And that 8-year-old was my son. And now I can go earlier than that, 6-year-old, my other son. Because what I truly believe is that needling has many, many benefits, many effects. And again, you know, the idea of acupuncture. Acupuncture has been around for thousands of years. Needling works, okay? So with him, that's the youngest I have. And to needle children, it's really, there's no negative to this. I actually spoke to a therapist yesterday that does pediatric care, and she's asking, can I needle a child with significant handicap? And I said, absolutely, you can. You just have to have informed consent of the parent, and you have to have somewhat consent of the patient, which becomes difficult in cognitively impaired people as well. But needling in children is fantastic. There's no negatives to that at all, other than the fact, can you get them on the table and convince them to do needling? With my 8-year-old, it was easy. Daddy, my ankle hurts. I explained what I was going to do. He goes, I'll try it. I started slow, and I worked up with him, and now whenever he has a problem, he says, Daddy, I need you to do this and do that, and he tells me what he needs now, whether it's manual therapy or needling. So it works out real well. And then my 6-year-old, I start with half-inch needles, just skin superficial, make it fun, let him play with it a little bit, let him kind of get comfortable with the process, and I slowly build him up. But I strongly believe that as they go through their sports, they're wrestlers, they're going to need needling through most of their athletic careers for sure. Can dry needling help with pain-associated fibromyalgia? I think I addressed that a little bit. Absolutely. I have, years ago, I really couldn't offer fibromyalgia patients anything, quite honestly. Go to the aquatics, because most of what you're going to hear is go do aquatics. Here's a stretch. Do this exercise. And you all laugh because none of that works, in that sense, right? I mean, it's something that so many people have failed. Adding in the needling into those peripherally sensitized nerve points and into the muscle has been one of the most fantastic things I have been able to do for my patients. And it gives them relief and allows them to function at a higher level. Does it cure it? It does not. It is a fibromyalgia, in my opinion, is a gut problem to start with. It's an immunogenic gut problem that crosses over to become a neurological problem. It occurs in the spinal cord, the central processing, and then it creates muscle pain and muscle function. But it's not a muscle problem, in my opinion. It's a muscle pain. So what needling has, it has, physiological processes that I can't provide in any other way to my patients besides dry needling. Doctors have abilities to do medications and different things they can influence in the central nervous system and physiology. I could never do that before. Now I can. So, yes, I do think it has benefit for fibromyalgia. You're welcome, Christy. Thank you. Can dry needling help with pain associated with fibromyalgia? That one. Thank you, Frank. I think I'm doubled there. Do you know anything about physiogenic pedal papules treatment with or without dry needling? I have no idea. I could barely even say it, so apologize. I don't know anything about that. One of your patients wants you to mention needles are one-time use, sterile. Yeah, so what you use with needling, infection. Let's talk about infection a second. My mentor has been needling for 40 years. He's never had an issue with infection. There is some new article that came out with looking at infection, and the only way, really, that you're going to get yourself into a situation of infection is if you're needling somebody who has unintact skin, somebody who has already a very, very limited immune system. But the needles that we use are sealed. They are sterile needles, and they're one-time use needles, meaning you're not using them on anybody else. You don't want to go to somebody who's autoclaving needles and reusing them, okay? Needles are cheap in that sense to buy. You should always be seeing your practitioner opening new packages and being able to needle you with that needle. And there really isn't, and again, I've been needling for 6 years or more years now. I've never, ever had a problem with that. So in the hands of a educated, trained practitioner, infection should never be an issue. Frank, did you mention that needle, just for clarification, do you elicit a twitch response in order to get benefit from dry needling? Well, you can needle. Twitching is a good thing. A lot of the literature that is in dry needling literature is focusing on performing that twitch. A lot of the acupuncture literature doesn't focus on getting a twitch. A lot of the literature in superficial needling doesn't do a twitch. Dr. Gunn's approach, IMT approach, doesn't necessarily do a twitch. So the idea that you need a twitch still remains controversial. Do I always needle people to try to get a twitch? I do not. Do I get results? I do. So the idea that when you go and get dry needling, some of the needles will twitch, some of them won't. I don't think you gauge your success or your failure based on that ability to have or not have a twitch. Has dry needling been helpful for TMJ in your EDS patients? Can you explain how this does not make the jaw looser and more prone to subluxation? Are there exercises to strengthen jaw muscles? Well, you know, again, going back to the idea that these tight muscles, or these trigger points, I should say, these trigger points are in some way holding your joints together, and that they're a good thing. I don't think it's substantiated in any way, shape, or form. When you release a muscle, a trigger point, if you will, what you're doing is you're improving circulation. That's really what you're doing. You're reducing tension, I think, in the contracted musculature. But for the most part, you're changing, improving circulation, which reduces the inflammatories. And that was shown in research, Shaw 05 and 08, Shaw's articles, show that you release that, you actually release the inflammatories within the area. So by doing that, that's when you lose the trigger point and you lose the tenderness of the area. But I don't think you're going to find that it's going to cause your jaw to be more loose in any way. In fact, as you start to improve the trigger point responses and you get rid of those, and you start to do, you know, and as far as exercises go, Deanna, it'd be hard for me to go over that online here, but as you do different exercises with the jaw and muscle performance becomes better, this is especially important in the jaw because jaw mobility is completely based on the function and the coordination of the muscles around the jaw joint. Okay, teeth play a role when you close, but in general, the muscles dictate how the jaw moves and if it subluxes or if the disc is in place or not in place or if it clicks. So muscle re-education in the jaw is extremely important, and it cannot be as effective if you're harboring trigger points in these jaw muscles. Is there anything that can completely get rid of a trigger point? I think that also that's never been done, Dave, in the literature where I needle you. Well, let's say I do an ultrasound, I needle it, and I come back 2 weeks later and I relook at it. Is it completely gone? The actual contracted aspect of that muscle may in fact be released, but yet in a month or a week or a day, that sensitivity and that tenderness comes back. So is it really the contracted muscle that's giving you the pain, or is it the inflammatories that are in the area, or is it the sensitized nerve that's in the area that's giving you the pain? That we don't really know yet. Okay, that's still pretty controversial. So when you say, do I ever completely get rid of it? My first thought and opinion would be we do not completely. We may get it better for weeks or months. If you're young enough and you have, the healing properties, maybe, where you don't feel that pain any longer. I kind of think of a cure, if you will, as not requiring additional treatment for upwards of a year. And things that return within months are probably more of a chronic situation. So I think a lot of patients that we see, chiros, DOs, PTs, see in their clinic are people who get better for weeks or months at a time, but then they come back with a similar problem, and that's in the same area, sort of the same presentation. So in those kinds of people, no, I don't think that trigger point, whatever it is, nerve, inflammation, or actually contracted muscle, ever actually goes completely away. Do some of your EDS patients tend to have more trigger points than others? Yeah, absolutely. Some of them have EDS that's more focal in that way, where they really seem to have problems in particular areas more so than others. So, yeah, they would definitely have more regional types of trigger points. Can dry needling help a muscle tear to heal? I think the short answer, again, depends on things. If you're talking about, like, say, a rotator cuff tear, I don't think that needling rotator cuff tears will cause tendons to regrow, of course. But when you look at muscle tears, I think improving circulation, exercise, movement, working on pain relief along those lines, I think it can, again, do that 35-mile-an-hour speed, maximizing the ability of that muscle to heal. I think you got to be careful in that area. You don't want to produce too much lesion, meaning too many needles, be too aggressive in the area from that standpoint. But in general, I think some light needling, some light muscle needling would certainly be something I would do and have done with patients for sure. Our EDS patients, especially special muscle tone differences. Our EDS patients, especially muscle tone differences. If I understand the question, does an EDS patient have a different type of muscle tone than everybody else? Yeah, I think, Deanna, your question, we had that conversation before, is some have this feeling of low tone. It's just like, it's not a muscular feeling of tone. It's just like putty, if you will, the muscle tone of some of the EDS patients that I see. And that goes back to the soft tissue problems that you all have, the actin, the myosin, and just the actual structure of it is different, both genetically, certainly, and structurally than other tissue. And in other EDS patients, it doesn't feel any different than somebody without EDS, quite honestly. Can you touch on some of the research studies on dry needling effectiveness? Yeah, if you go to, I could talk 3 days about that actually, which I do, but if you go to integrativedryneedling.com, right on the front page, at least right now, I'm going to change that, but right on the front page, it actually lists on a PubMed feed. PubMed is where we have all the medical research that's out there. Everything that says dry needling within the text of it will be put on my front page. So you'll be able to actually look, like just recently there was one on heel pain that was poorly done, but there's one on heel pain, there was one on thoracic pain, there's always a lot on cervical pain. And there's systematic reviews. So you can actually go through and look at one article that lists all the other articles that talk about dry needling in areas like cervical pain. But just as a general comment, we need more research on dry needling. And that research is coming. And we need more quality research, like anything else. So that's coming. But, if you really look at it as a whole, the vast majority of that research is pointing to the indication of effectiveness of dry needling dealing with musculoskeletal injuries.
Okay, and I think that was the last question, Frank?
Yep. I think so.
Okay, super. Well, thank you so much for your patience with all of our questions. You answered them wonderfully, and boy, I hope this presentation encourages a lot of the EDSers out there to give dry needling a try. Certainly everyone in my support group has tried it, has just been very delighted with the results and has continued on. And it's really helped us tremendously with our pain management and also trying to get back up and active again and be able to tolerate more exercise. So with that, I just, do you have any closing remarks or anything you would like for people to take a look at?
Yeah, I think educate yourself on it. Again, it's not the I don't want to call it the savior, but it's not the only thing that you can try. I mean, it's something that people, and a lot of people I've had have tried a number of other things. It's certainly something that I think can have benefits. Go into it with an education, meaning go on the site, read some of the articles, the positives, negatives, and certainly educate yourself on it a little bit more. Careful when you go onto YouTube and different areas as well. They show some techniques and stuff that aren't exactly what mainstream along those lines. Like anything with the internet, it's hard pressed to believe everything you read or you see. But it's certainly, I think, worth a try when you try everything else. And find yourself a practitioner who's been trained appropriately and has been doing it for a bit of time. And they can also bring other things to the table, manual therapy and some of the other educational things that these practitioners have. So with that, I think we're good.
Okay,
great. Thank you, Frank, and we certainly appreciate your presentation. This is a unique topic that we haven't had on our calls before, and I think something that is going to benefit many of our EDS members. We will have the recording on the site tomorrow, so feel free to start back, and if you missed something or maybe missed the front end, feel free to listen to it again. It will also be posted on our YouTube site. Our YouTube site, EDS Awareness 1 on YouTube. We also like to remind you that we have another webinar scheduled for December 3rd. So Dr. Ross will be on at that time talking about sinus issues related to Ehlers-Danlos. So please check that out. Also remind you that this program is sponsored by a Body Support store. So please go out and check out our store. We have a variety of products, including a number of braces and pillows and mattress and neck wraps and others. So please feel free to go out and buy a product that helps fund this program. So with that, I'd like to conclude our program and thank you for all that have continued on with our program to the end. So have a good evening and good night.
Good night, everyone.